us on the map. Mr. Caruana leading the beat. Australia global rank 6. Feeling the heat like immortality.
So in today's video, we are looking at health expenditure, and primarily the health expenditure and its impact on current, but also future populations. So what is health expenditure? Health expenditure, in a very general sense, is all money spent on health goods and services here in Australia from all levels of government. So in the past few videos, we've been looking at different levels. So you've got, government, private, non-government organisations, okay? All of these comprise money that is therefore spent in health expenditure, and they lump that all up and say, well, that's our health expenditure for the country. So the first part we need to specifically look at is our healthcare versus prevention, all right? So do we spend the money on making people better and diagnosing what's wrong with them, or do we spend the money on preventing them from getting sick in the first place? You might be surprised to hear this number, and I certainly was. I knew it was high, but I didn't know it was this high. Currently, 98% of all health expenditure in Australia is on healthcare/primary care, okay? In other words, treating and managing illnesses and all the things that go along with that, like infrastructure and stuff. So I've given this list just broadly, hospitals and everything in the hospital system, medications, clinics like GP clinics, etc., transport to and from hospitals in different places. So everything that is used in basically the managing, diagnosing, treatment of illnesses and patients is 98% of all expenditure. Only 2% of our national budget every year is spent on preventing people getting sick. Things like vaccines, screening, and the ones that you will most likely think of are campaigns like Slip, Slop, Slap. All right? So I might just write that there. 2%. So we're talking like millions of dollars here. Actually might be up in the billions. Pause, I'll find out. So I've got data from 2022-23, $252 billion was our health expenditure number for that 12-month period. So you can imagine that's even higher now. And only 2% is spent on actually stopping people getting sick, which seems silly, right? Because spending more money on preventative health is going to therefore lessen the amount of money that we're spending on treating people, which therefore makes sense. It's way more cost effective. I should write that up. Cost effective to spend money on people before they get sick, because once you're treating someone, that costs a lot of money. Now, why don't we just shift it? Why don't we, even make a slight shift? Why don't we go 90%, 10%? Okay, think about it. So the National Preventative Health Strategy aims to shift more of the money to preventative health and wellness rather than treating illnesses, but there is resistance, obviously. The resistance comes from the current population and politicians in particular, because they're at the policy level making these decisions, because they need to fix current health issues, okay? So imagine if we, let's just put ourselves in a time capsule or whatever and go, okay, we're going to shift 18% away from current health expenditure in primary care, and we're going to put that into preventative health. What would happen? Okay, so now we've got like an 80-20 split. Well, first of all, a whole bunch of people would continue getting sick and probably die, because while this number is massive, it is a needed number because there is that many sick people needing care and treatment and diagnosis and transport and medications, et cetera, in our current system in Australia. So if we shifted away 18% of all expenditure, people are going to die, okay? Or they're going to be medically retired from their job because they can no longer work, because what they were receiving treatment for, they can no longer afford to get that treatment, so they've got to, sit at home, and then mental health goes down, and then, bad things would happen, all right? What benefit would we get from all the people dying or being sick for the rest of their lives? Well, nothing immediately, because preventative health is a long-term investment. I should probably write that up too. Long-term investment, right? So immediately, a whole bunch of people are going to get sick and die, and we're going to see no benefit from it. And this is why the politicians are like, well, we're not going to do that because all we're going to get is an unhappy population in Australia. However, if you then fast forward 50 years from now, you would see probably a massive reduction in this number because there is a huge population who are no longer sick. They're able to retire at 67 and they may not have disease anymore because we shifted a whole bucket load of money into preventative health strategies, and everybody knows what to do and what not to do, and therefore everybody's doing those things and everybody is healthier, okay? So long term, very, very good decision. Long term, very cost effective. However, short term, many negatives, all right? And this is a constant battle. And like I said, I'm not the one making the decision. So I wouldn't want to be in those shoes either. But it would be an interesting debate to have. And I'd probably pay to watch it on TV. If anyone from the television channels are watching this. Not that you are. No one watches these videos anyway. Anyway, that's healthcare versus prevention. So in this next section, we are looking at sustainability and equity of access, okay? So sustainability refers to the ability to maintain current health funding over time, okay? Rising chronic diseases, all right, CVD, cancers, dementia, all right, requiring ongoing care, as well as the aging population requiring beds and aged care facilities, etc., is putting great financial pressure on and financial sustainability, all right? So current expenditure projected is not sustainable, all right? So we need to do something about that, all right? Things that we could do about it is that you could pass those additional expenditure onto all Australians. So the tax rate may go up, right? And then everyone is, like, we're already complaining about cost of living. Well, that's going to go up because of the healthcare system, okay? Or you could redirect funds from other systems, like you look at the, like the roads and traffic system in Australia. Maybe you're going to take away money from that. Or you could take money away from the education system as another example. So money's got to give somewhere, okay? You can't just print more money. It doesn't work that way. Although I wish it did. I wish I could print money too, but I can't. Next one, we've got equity and access. So this is making sure, and this is partially how Medicare operates, and we'll get to that in the next bit. But we need to make sure that all Australians can access healthcare, all right? So expenditure is also used to remove barriers from healthcare access to make sure that we can all get it. First Nations people, rural and remote communities, people in low SES communities, etc., should all be able to access healthcare equally in Australia, all right, as opposed to normal people or rich people. Now, that's not to say that everyone can access private health insurance. That's different. But everybody who, needs their knee reconstruction, or everyone who needs their cardiovascular disease looked after in a public hospital should be able to access that, all right? And part of the expenditure is used on removing those barriers, all right? So for example, doing more telehealth, right? We talked about the National Digital Health Strategy in a previous video, so expanding that system so people who live remotely can access a GP 24/7. Doing more remote screening, through mail kits, or maybe having vans that travel places, all right? Or just by simply building more public facilities, in our local area. Yes, we've got John Hunter Hospital and we've got the Mater Hospital. Build another hospital, okay? I can guarantee you it's not going to be empty. It's all of these things, but they all cost money, right? Money's got to come from somewhere. Now, an example for you guys. The 2024, so 2023-24 federal budget tripled the bulk billing amount, all right? So remember we spoke about bulk billing and how people have to pay gap fees, but more doctors these days are bulk billing because they're getting more money from the government to do so, all right? So this incentivizes GPs to not charge gap fees to patients, which is excellent. This is removing a barrier. Okay. However, the government obviously tripling the bulk billing amount, that's now money coming out of government and taxpayers for GPs, all right? So further driving up health expenditure. They also dedicated greater money towards services and building new infrastructure in rural and remote communities. More expenditure, all right? Both of these measures improve equity and access to healthcare. So I'm not saying these are bad things. These are good things, providing you're not the financial guy in the government trying to piece all this together. but they do further drive up health expenditure, making current expenditure potentially unsustainable. So the rate that we are currently spending money in health expenditure in Australia is probably going to be unsustainable when you account for the rising chronic diseases and aging populations who are going to be requiring ongoing care in the future. Which is why health promotion and prevention or preventative health measures need greater funding. If there are less sick people and there are people that are able to look after themselves in elderly age, then that's going to massively drive money down. But once again, as we talked about in the previous part, you don't want to take away money from the people that need it right now and give it to people who will potentially need it in the future. It's a hard call. So that's sustainability, equity, and access. All right, so our last part looking at our health expenditure and its impact in Australia is looking at Medicare, private health insurance, and Commonwealth funded programs here in Australia. So firstly, Medicare. So Medicare was established in 1984. Side note, so many good things come out of 1984. Best year. The best. Anyway, so Medicare, established in 1984, is funded by taxpayers, 2%. So any income that taxpayers earn over a certain threshold, I think you've still got to earn over the tax-free threshold, which is like $52,000 or something like that. 2% of that goes towards Medicare, okay, to fund Medicare. So that money is therefore provided to give individuals free access to public hospitals in Australia, provides the bulk billing for GPs and specialists. And remember, we talked about that in the previous video. So GPs and specialists elect to either bulk bill or then they can elect to charge more, and then you pay the gap fee as the individual. Medicare also subsidises medications via the PBS or Pharmaceutical Benefits Scheme. And finally, offers protection from high out-of-pocket expenses via the Medicare safety net. So the safety net's an interesting one. Basically, if you have $2,500, did I write it? Yeah, so $2,500 in a year of out-of-pocket expenses, so gap fees, okay, then Medicare will step in and pay 80% of everything else, all right? So you're unlikely to get $2,500 worth of gap fees for doctor's visits, but a common example is like during pregnancy. A lot of people go and see obstetricians. Their gap fees can range, anywhere from like $300 to $500 or more. All right. So for example, if an obstetrician charges $500, a $500 gap fee, and then over the 9-month period and you end up paying more than $2,500 out of pocket expenses to the specialist, Medicare will then say, oh, well, you've hit the Medicare safety net. So they will then pay 80% of all other remaining appointments that you have with that same doctor and specialist. So that's really good. Running concurrently with Medicare, we have private health insurance, okay? So you don't have one or the other. You either have just Medicare or you have Medicare and private health insurance in Australia. So private health insurance will cover services which are not included with Medicare. Common examples would be, dental, physio, optical, etc. Some of these are done at a percentage rate. So like a physio, for example, may, depending on which provider you're at and what tier you're on, because there's like gold, silver, bronze, basic for private health insurance. Most tiers offer different percentages, but let's say you're on gold, you may get 65% back of whatever the physio charges. So if you go in to see a physiotherapist for an injury, they charge $100 for your visit. Your private health insurance will claim 65% of that, so then you only have to pay out of pocket $35 for the physio visit, which is excellent, but you're still obviously paying for the private health insurance. All right. So to maximize the most of your private health insurance, you should really be using it to cover as many services as possible to make sure that you're getting your best bang for buck, right? Optical and dental, they're like flat rates. So for example, with optical, most of them offer $250 or $300 per year towards, glasses or contact lenses or whatever you need, right? But that's not the real reason that people get private health insurance. The real reason are the following. Choice of doctor in the hospital system. So if you ruptured an ACL and you need to get surgery, okay? You go through the public health hospital system via Medicare. They will obviously perform the surgery on your knee for your ACL, but you may have to go on a very, very long wait list for that. It could be 6-7 months down the track until you're able to get your ACL repaired. And that whole time you'll be like on crutches, in a brace, etc., etc. However, with private health insurance, and you'll get whatever doctor is available on that date that they've determined for you. So in the private health insurance, you can choose which doctor that you actually see, all right? And you can also skip the queue for surgeries via the private hospital systems and private clinics, okay? So let's say, there's Dr. Goodleg, okay? Dr. Goodleg owns a private practice at Charlestown where he sees clients on Mondays, Tuesdays, and Wednesdays. On Thursday and Friday, Dr. Goodleg operates a clinic at John Hunter Hospital, okay? So on Thursdays and Fridays only, he goes to John Hunter Hospital. He is therefore sort of done via Medicare. He will see patients, do consults, and he may do some surgeries on those days too. The other 3 days of the week, Monday, Tuesday, Wednesday, he runs his own private practice. He does the same thing, consults, surgeries, etc. He may do his surgeries at like Newcastle Private Hospital or Lake Macquarie Private Hospital, but he does the consults out of his office at Charlestown. If you have only Medicare, all right, then you can only see Dr. Goodleg on Thursdays and Fridays, and you might get lucky and you might rock up because you've got your ACL injury and he just happens to be the knee specialist on that day. However, if you have private health insurance, you can book in with a referral from the GP and you can go and see him next Monday, and then he may get you in for the surgery in 2 weeks' time because he's got an availability, all right? So private health insurance allows you to skip that system, allows you to choose your doctor. It's very beneficial, all right? The government also will charge income earners over $101,000 a Medicare levy surcharge. This is doubled to $202,000 if you're a family, all right? And they charge you that surcharge at tax time. You do not to cover the expenses of, so this basically incentivizes people who are earning more money to therefore get private health insurance, okay? Basically, the government is trying to avoid people who have lots of money using the public system, creating the bed block situation that we talked about in previous videos, right? If you have lots of money, you shouldn't be taking away a bed, taking away resources from people that don't have lots of money. You should be able to pay extra to skip the queues and do all this kind of fancy stuff in the private system to then free up the public system for people that need it more than you, okay? So we talked about equity and access of care, all right? Some people need the public system because they can't afford the private health insurance system. If you can afford the private health system, you should go that way, okay? So this surcharge basically is the government's way of saying, hey, come on, step up, pay it, all right? And you only need to have basic hospital cover to avoid this surcharge, and it ends up being, I think basic hospital cover is about, for the year, I think it's about $1,000. I could be wrong. Okay, I'll look it up another time. You can look it up. There you go, homework. You look up how much basic hospital cover is to avoid the Medicare levy surcharge, right? But if you don't have it, at tax time you get hit with a bill of about between 1 and 1.5%. So it could be so if you're just earning this amount of money, it would be $1,000 or $1,500. But obviously, if you're earning like $300,000, then that would be escalating a lot higher. So that's Medicare and private health insurance. I'll rub this off and then we will go through our Commonwealth funded programs. So finally, we're going to look at our Commonwealth or federal or national, however you want to think about it, funded programs. Okay, so Commonwealth government, federal government, it's all the same thing. Just be wary of the terminology, all right? So the two common ones which I've talked about in previous videos, we've got NDIS, National Disability Insurance Scheme, and My Aged Care. So the NDIS provides funding support to individuals with disabilities to enable independence and community involvement, okay? So the NDIS will help subsidise or just purely provide services such as transport, home services like domestic services, psychology, occupational therapy, depending on the person and their disability, all right? Now, the NDIS is open to anyone. You can be child, middle-aged, elderly, it does not matter. Age is not a concern, but you do need to have, obviously, a official diagnosis from a doctor. You can't just call them up and say, hey, I can't do X, Y, Z. That's also not very respectful to people with disabilities, all right? So it is there to implement these things to hopefully enable people with disabilities to still live fulfilling lives, okay? So they don't feel like they're just, oh, I have a disability and therefore I'm bedbound or chairbound for the rest of my life, okay? So it's great. The NDIS is great, all right? But it does come out of the overall health expenditure in Australia, which we already talked about, is probably growing at a rate that we can't sustain. The other one is My Aged Care. So this one's interesting. So My Aged Care is a portal. It's run by the government. It connects aged individuals with a variety of services to enable independence, quality of life, and for them to ideally stay at home. Things that My Aged Care can offer are like home care packages, providing cleaning, domestic services, transport, home modifications to keep them safe in home, like, you know, railings and non-slip boards, etc., etc. So My Aged Care is interesting because, yes, that once again is going to come out of the health expenditure funds. However, keeping those people at home costs significantly less than it does than putting them in an aged care facility for 24/7 care. So this one is sort of like, I'm not going to say it's cost neutral, but it's definitely very beneficial. NDIS, mind you, is still beneficial because if those people weren't getting these services, they would probably be in the hospital system for maybe like mental health and wellbeing issues because, you know, they're not getting out, they're not socializing, etc. And we know that those things are very, very important for avoiding things like dementia down the track. But these programs are good and they are tailored in a way that is designed to lessen the burden on the healthcare expenditure ongoing, all right? So that'll end the video here. I do want to leave you with the overall question, and the crux of the video is like, what would you do, all right? If you had loved ones, your parents or your grandparents who were reliant on medical services day to day or maybe week to week, depending on what their conditions are, you know, could be just aged care, could be dementia, could be cardiovascular disease, could be cancers, dialysis, something that they need ongoing care for. Would you be happy if the government came out and said, we're cutting off financial support for all the people that have cardiovascular disease, okay? It's a disease of the lifestyle, so you guys can either privately pay for all your treatments and care that you need for that, or you can suffer the consequences. However, at the same time, we're taking that money and we're investing it in these new policies and prevention schemes for cardiovascular disease, all right? So the goal here is obviously to prevent people from getting cardiovascular disease in the future. So that could be you and me, right? Watching this video, you'd be like, okay, well, the government are going to invest to make sure that I never have cardiovascular disease, which could be excellent, all right? Health prevention. But in doing so, you have to make the people that currently have cardiovascular disease suffer. Like, what would you do? It's the trolley problem, right? Would you, flip the switch so that one person suffers and you get to benefit, or would you flip it the other way so that, no, you don't really care about yourself, you want your loved ones to not be suffering? Anyway, it's a hard thing, all right? And like I said at the early start of this video, I wouldn't want to be responsible for making those decisions. So yeah, that's enough of me talking, and that's the end of our health expenditure and its impact on Australia's population. Thanks.